Pneumonia is the inflammation of the portion of the lungs, including the alveoli, alveolar ducts, and respiratory bronchioles that contribute to respiratory gas diffusion caused by a bacterial or viral infection. Alveoli are tiny air sacs at the end of the bronchioles that are surrounded by blood capillaries. Oxygen from inhaled air will diffuse into circulation, where it will bind to hemoglobin via the respiratory membrane on the alveoli wall. Simultaneously, carbon dioxide as a byproduct from cell metabolism will diffuse out of circulation through the respiratory membrane into the alveoli to be expelled via exhalation. Inhaled air has the possibility to present harmful microorganisms. Normally, ciliary mucus in our respiratory tract will trap and expel via coughing. In the case of pneumonia, however, either from epithelial damage or by sheer chance, the ciliary mucus are unsuccessful and the harmful microorganism reach the alveoli. To deal with the infection, inflammation will occur, increasing capillary diameter and permeability to allow white blood cells or leukocytes to exit the capillaries to fight the multiplying bacteria or virus. However, leaky blood vessels lead to an exudative fluid accumulation within the alveoli, consisting of active and dead white blood cells, fibrinogen, and necrotic or dead cells. Fluid residing in the alveoli dramatically decrease available surface area for the diffusion of oxygen into the blood, as oxygen cannot easily diffuse through liquid, increasing breathing difficulty and decreasing gas exchange, decreasing perfusion to cells, inducing hypoxia, cell necrosis, and eventually organ failure. This is a leading cause of mortality in hospitals, particularly in older and immunocompromised patients. Pathology is similar to a gas mask where the filter becomes wet, clogged, or breaks. It will not filter the ambient air correctly, resulting in minimal clean air reaching the wearer, causing respiratory problems. Two subsets of pneumonia. There's typical pneumonia, which is generally caused by a larger, more common group of bacteria that have a cell wall. This has two manifestations as bronchopneumonia, which is a patchy spread of pneumonic alveoli and bronchioles in multiple lobes of one or both lungs, and lobar pneumonia, which involves an exudative accumulation in the intra-alveolar cavity, impacting the entire area of a lobe of the lung. We have atypical or walking pneumonia, which is a viral or mycoplasma infection, which is a type of bacteria without a cell wall, involving infection of the alveolar septum between two adjacent alveoli and lung interstitium, called interstitial pneumonia. Pneumonia is also categorized by the setting it was acquired. Community-acquired pneumonia is normally diagnosed within 48 hours of a patient being administered to hospital who has not resided in a long-term care facility for 14 days or more prior to admission. Hospital-acquired pneumonia is diagnosed after 48 hours or more in hospital. Patients requiring intubation and medical ventilators are particularly at risk, and it's generally harder to treat from bacteria acquiring antibiotic resistance. Pneumonia as a disease causes more than 1.25 million hospitalizations annually. Streptococcus pneumoniae, which is most common in the community setting, produces one case in every 100,000 people in New Zealand. Bacterial pneumonia in the hospital setting, like Staphylococcus aureus, are more resistant to antibiotic treatment. Viruses such as influenza, respiratory syncytial virus, and fungi manifestations of pneumonia are less common. Imagine hospital-acquired pneumonia as a bacteria that is constantly training against the antibiotic environment that the hospital presents. As a result, it gets stronger and is able to resist treatment for longer, prolonging symptoms. Manifestations and symptoms of pneumonia include dyspnea or shortness of breath when resting, productive sputum cough, chest pain which can quickly turn into pleurisy, fever, pale coloured skin from a sympathetic peripheral vasoconstriction, rapid heart rate, and in rare cases fatigue with joint and muscle pain, and hemopoptosis, which is coughing up blood. X-ray can be used to display infiltrates to identify infection spread in the lung and the type of pneumonia present. Comorbidities include asthma, COPD, hypertension, immunocompromised patients, and any sort of cardiovascular condition.